I'll take about 15 minutes of your time to talk to you on how to prevent a patient with diabetes, person with diabetes. The idea has changed the terminology. It's a person with diabetes from going into the hands of the surgeon. And this is expensive because it's expensive. So we have about 80% of people who have a normal foot. We have about 10% of people who have a high risk foot. And we have 10% of people whom we see in the outpatient clinic who have an ulcerated foot, necrotic foot, an unsalvageable foot with complete necrotizing fasciitis of the entire foot and so on. Yesterday morning I saw a patient with unsalvageable foot and I told him below-knee amputation is the only hope because it has gone beyond the ankle. The infection is spreading and he's got a necrotizing fasciitis. No pulsation. So I told him that best thing is to chop off the leg. And I was with this podiatric surgeon. So I think we should listen to this good staging protocol from Mike Edmonds' group in London, from Mike Edmonds and Ali Foster, who's no more, who died of cancer 2 years ago. And this is the normal feet, high risk feet, ulcerated feet, infected necrotic feet. Very simple staging. Very simple staging. And this is a natural history of the diabetic foot, which we all see. This was a paper in 1997, which we wrote up for the IDF journal. There's no IDF bulletin now. We found that people with diabetes walk barefoot. They have neuropathy, about which I'll talk to you about in the next 5 minutes. And there are social cultural practices that predispose a person with diabetes to foot ulceration. This is one of the social cultural practices, the wearing of the Hawaii chappal. It costs about 100 rupees, I don't doubt it. It's meant for the bathroom only. It provided you're having a bath for 10 minutes. Not even half an hour in the bathroom. So if you're giving yourself a wash for 10 minutes, you can use the Hawaii chappal because that will produce, this is from my late friend Sharad Pense from Nagpur, who gave me the slide, and you see how the Hawaii chappal has caused damage. So this is the socio-cultural practices about which we're talking about. So in the last 10 minutes, 9 minutes of my time, let me talk to you on the early diagnosis of diabetic foot complication. Now, the first sensation to be lost in a person with diabetes is the small fiber. Now, you can follow the small fiber testing as told by Riaz Malik, who was from Manchester, then he's from Pakistan, and now he's in Qatar. You can look at the corneal confocal microscopy. But it's very expensive. It's 25 lakhs. So what we do is we do a temperature testing. And fortunately in Chennai, we have two companies, the Cody's Electronic and the other company, which produces a sensitometer for temperature testing of the small nerve fibers. So you simply keep the temperature, the cooling and the hot temperature, and see the difference. Ask the patient to close his eyes, otherwise he will not give you the right answer. So close your eyes and test. Monofilament is tested for the large nerve fiber. So small nerve fiber and the large nerve fiber. The large nerve fiber is tested by the monofilament testing or by the vibration testing, about which I'll tell you in a minute. And we, along with the Diabetic Foot Society of India way back in 2003, validated the indigenously made by this meter. So you don't have to spend a lot of money importing it from the United States, but you can get it from India. You can get it from Chennai, I think. So this is a study. I'm sure Prem Kumar sir will agree that the handheld Doppler is a very useful instrument for testing the peripheral arterial disease, as it is called now. Not peripheral vascular disease, peripheral arterial disease. You can feel the posterior tibial and the dorsal respirator artery. Many times due to cellulitis in the feet, you can't feel it. So you can use the handheld Doppler, pocket Doppler, which costs only about 30,000 rupees. And I think every physician should carry the handheld Doppler in his pocket. And on the right hand pocket, and on the left hand pocket, the tuning fork to test the large fiber. We have the 1 minute test. It takes only 1 minute to test the blood circulation to the feet. If you're not happy with the handheld Doppler, with the sound it makes, and you can actually measure it. I'm not giving you the sound. If you get a triphasic wave, the sound, it is normal, the normal blood flow. You can ask your plastic surgeon, sir, to operate. So this is how we do it in Chennai. We do the 1 minute test. We have a more elaborate testing, the vast lab from Chennai, which can test the blood circulation, look at the ABI, TBI, and the toes never calcified, mind you. The entire foot can get calcified, the ankle brachial index can be more than 1, but the toe will never be calcified. So you can depend on the TBI, which is more than 0.7. If you have a toe brachial index of more than 0.7, you do not have peripheral arterial disease. So deformities are present in the Indian patients due to poor footwear, and you can see that the crowding of the toes, the claw toes, flat foot, the high arch foot, all are very common in India due to, these are the photographs of the same thing what I showed you in the previous slide. Flat foot is there in some people, so watch out. Not all these people require a MCR. You need a molded footwear, like you make in Karigiri, which is very close to Vellore. And you need a customized footwear, which about 30% of people will require. So 70% do not require a customized footwear, about 30% would require a customized footwear, where you accommodate the deformities in the foot. This is something which Dr. Prem Kumar will appreciate. This patient was referred to us for a below knee amputation. You can see the heel is infected. It's a dry gangrene, unhealthy calcaneum is exposed. So anybody would say that cut off the leg. But we revascularized the limb. We did angioplasty. DSA is a good test. If your TBI is less than 0.7, you ask a DSA to be done, or a CT angiogram or MR angiogram to be done. We do a DSA, and we do an angioplasty in the same sitting, and we do the wound debridement, and it healed. We needed a plastic surgeon, Dr. Lamba, to do the skin grafting, and the skin grafting was done. The artificial skin is used sometimes. And I would like to end with this neuropathy disability score. All that you need, I've been asked this question, how many rupees do you need to set up a foot clinic? You need only about 50,000 rupees. You don't need more than that. You need only a 128 Hertz tuning fork. You need a temperature testing like the sensitometer. You need a sterile needle with the other end, not the sharp end, but the other end. And you need an ankle reflex to be tested. And you give 2 points for the ankle reflex to be lost. If it is lost, 1 mark, 1 point, one mark if the right and left are impaired. And what Andrew Bolton and Caroline Abbott have shown in Manchester is more than 6. If you have more than a score of more than 6, so 2 here plus any of these 1. If you have more than 6, your chances of out of NDS out of 10, totally you can get 10. So usually most people have 10. But if you have more than 6, then you are likely to ulcerate within 2 years or 3 years. They did a follow-up study and they found a score of 6 to be predictive of an ulceration. So you use a score like an NDS scoring sometimes to corroborate what you see, because individual testing has got a sensitivity and specificity of 70%. But if you do multiple testing like this, you get straight away a sensitivity specificity of 90%. So this is the advantage of the neuropathy disability score. Don't forget that limited joint mobility, Andrew Bolton showed in the Asian Indians that limited joint mobility does not exist among the Asian Indians. But we proved him wrong, and we showed that limited joint mobility in the hands it is tested by the prayer sign. Here it's easy, but in the feet, how will you test the prayer sign? You can't. So you do the dorsiflexion of the big toe. And if you have a hallux rigidus, and you can use a goniometer to test the range of movement at the subtalar joint and so on. So if you have limited, we use the ROM, the goniometer for this study, and we measured the high plantar pressure. I was the first in India to purchase a machine from Germany to measure the pressure under the foot by using an in-shoe pressure measurement. And we showed an association between limited joint mobility and high plantar pressure. And that causes diabetic foot ulceration. So if you have neuropathy, if you have limited joint mobility and a high plantar pressure, you can tell the patient that he is going to ulcerate. We have the Ashu Rastogi coming in. He is the secretary of the Diabetic Foot Society of India. Welcome, Ashu. We did the study in India, looking at about 30 centers from across India, and we had 1985 subjects. We were looking at the cause of amputation, and we found that the cause of amputation was neuropathy. Peripheral artery disease is there about 20-30%. But it was, we did this as an inpatient study, but we had an outpatient study with Nihal Thomas from CMC Vellore and Nikhil Tandon from All India Institute, and we found it only about 6% of amputation and peripheral artery disease and so on in the population, in the outpatient. In the inpatient, it was about 30%. And last slide, can we educate people and prevent amputation? Yes, we can. You have to have a good education of the feet. I told you sociocultural practices are very important, and I think it's very important to impart foot care education to people, and we have published this in Diabetes Care, where one group of patients were not given proper advice just once. Another group was given, otherwise the ethics committee won't agree. So one group was given standard care, just one advice. The other group was given constant advice each time they came for follow-up. And they were asked to come for follow-up. And we found that there was a positive impact of education. So the Sharat Pansi and I started the first time the step-by-step, and later on we included Arun Bal and the podiatrists from UK, London and so on, Ali Foster and so on. So this is how we educated the doctors in India, Pakistan, Bangladesh and in Sri Lanka. 4 the countries were covered in 4 cities, and this was in 2004, 2005, and Sharat Panse was the course director, he is no more, and I was the second in command, and there were others also, surgeons also, but diabetologists were the key people. So I would like to conclude with this statement from the IWGDF, which says, and it's not wrong, regular inspection and examination of the at-risk foot. You have to identify the at-risk feet. You have to find out which person has got a peripheral artery disease, which person has got a high-risk feet, and educate the patient, family and healthcare providers. Appropriate footwear. You don't use a Hawaii chapel except in the bathroom, as I told you. And treatment of non-ulcerative pathology, that refers to a callus removal of a callus, which adds to the pressure.
My talk is on the surgeries of the foot, but I would like to just focus on the surgical offloading of the diabetic foot. When we see the life cycle of the ulcer that a patient has in diabetes, it starts off with a callus, then it becomes a superficial ulcer, goes on to develop a bone deep ulcer, develops infection, necrosis, ischemia, and then goes on for amputation. Now when a patient comes with a callus, usually that is the time when some kind of an offloading, like a medical offloading, which Dr. Felix will be speaking, is offered to the patient to prevent that callus or to become further ulcer. If the ulcer has developed into a superficial ulcer, again it is managed medically with footwear, but there can be some compliance issues with the patients, and there can be issues with recurrence of those ulcers. So in those cases, surgical offloading can be offered. If the ulcer is bone deep, usually it goes for debridement and maybe a cover, as Dr. Vijay was talking about. And if there is a gangrene, this goes on for amputation. So I'll just focus on the surgical offloading today. We all know that WHO estimates that every 30 seconds a leg is lost somewhere in the world because of diabetes. And the incidence is more so 22 times in diabetics than in non-diabetics. And foot ulcer usually precedes these lower limb amputations. And the majority of these amputations are preventable if these ulcers are treated at an early stage. We all are aware of the pathophysiology of these diabetic ulcers. It's a triad between neuropathy, limited joint mobility, and ischemia. The neuropathy, basically these patients have motor neuropathy with intrinsic muscle atrophy, which causes the formation of deformities and the loss of padding because of soft tissue atrophy. This, along with sensory issues, they are not able to know what kind of problems they have until they develop complications. And they have some autonomic issues with imbalance in blood flow and reduced skin moisturization because of autonomic neuropathy. The limited joint mobility is basically because of alterations in the properties of elastic and collagen fibers because of deposition of age-related products. And this leads on to development of callus and further ulcers. An ischemic or a dysvascular foot is usually a foot where you don't have palpable pulses or an ankle brachial pressure index of less than 0.9. So these patients usually should be evaluated by vascular surgeons to know how much blood flow is going on in the foot. Surgical offloading is defined as a surgical procedure undertaken to relieve mechanical stress from a specific region of the foot, and it typically involves certain procedures like Achilles tendon lengthening, metatarsal head resection, osteotomies, arthroplasties, osteectomies, exfix, tendon transfers, tenotomies, tissue fillers such as silicone or fat, and I'll be taking few of these further. Now, why we need a surgical offloading when medical offloading works? Again, there are just two issues. One, a non-compliant patient or a patient who is developing a recurrent ulcer can be offered this kind of thing. However, there are issues with surgical offloading as well as with any other technique. So now, ideally, these patients are the ones who's got a superficial ulcer which is just up to the subcutaneous tissue. It hasn't become bone deep. When these ulcers are bone deep, then they usually undergo debridement and are not fit for these kind of procedures, and probably a flap. First, coming on to the various areas where these ulcers usually come and what kind of surgeries we can offer them. We all know 1/3 of the ulcers are usually seen in the great toe area, and there are mainly of two kinds: the plantar helix IP joint ulcers and plantar helix subungual ulcers. First, coming on to the plantar helix IP joint ulcers, again they are because of the reduced mobility of the first metatarsophalangeal joints, causing increase in the plantar pressures at the IP joint. And they can be structural or functional. The initial stages, it's a functional deformity. Later on, it becomes what we call as hallux rigidus, where the mobility of the joint is totally lost. Coming on to the management, if you have a patient who's got IP joint ulcers with a functional hallux limiters, what is recommended is just do a selective plantar fascial release at the on the medial arch at the metatarsal joint level, and this release will cause the intrinsic tightening to go, and it will help in the mobility of the MTP joint. However, if a patient has got a hallux rigidus or a recalcitrant IP ulcers, which is unresponsive to conservative measures, the surgery that can be offered is a Keller's excision arthroplasty. These patients usually undergo the base of the proximal phalanx is usually excised along with the intrinsic attachments which are there. This usually leads on to a small toe, but it becomes a mobile toe rather than a limitedly mobile toe, and it helps in the ulcer to heal. If it's a plantar subungual ulcer, usually the treatment is the flexor hallucis longus tenotomy. This can be done both by an open procedure, or nowadays it is done percutaneously with a small 16 gauge needle, which can be done as an OP procedure, and it is a commonly done procedure. The only thing you need to understand is you need to know that the foot vascularity is intact when you are doing this procedure, and it is a very basic procedure which can be learned and can be done in an OP setting, which releases the contracture, and you see the results on table. However, the problem is if you're releasing only the one contracture, their transfer ulcers can still be present. Coming on to the ulcers of the minor toes usually can develop what we call a mallet deformity, where again there is a flexor tendon contracture, which will need again a tenotomy, which presents as a mallet, or we have a claw toe where a girdlestone talar tendon transfer is recommended. When it is a fixed deformity, then probably an arthrodesis in neutral position is what is recommended. One of the representative photo for a mallet toe, before and after correction. And in girdlestone transfer, what we do is we recreate the intrinsic function by transferring the long flexor of the toe dorsally to the extensor expansion, and correct the MTP hyperextension by lengthening the extensors in a Z fashion. Coming on to the forefoot ulcers, they are mostly located under the metatarsal heads. When they are present, it is likely they are associated with a pronated or a supinated foot, or an ankle which is an equinus, which should be looked for. They usually don't occur in isolation, and if these problems are not corrected, they are most likely to happen again. For the first metatarsal head ulcer, usually the surgery is aimed at head preservation, and what is recommended is a Jones transfer, which involves transferring the extensor hallucis longus to the first metatarsal shaft along with the fusion of the IP joint of the great toe. If the ulcers on the minor metatarsal heads, the excision of the involved metatarsal head is recommended, but nowadays what we can do is through the dorsal approach, you can do a percutaneous osteotomies on the head of the metatarsal, which releases the head, and whenever the patient is walking, rather than causing the plantar pressure, the head is offloaded on its own. So this can be done percutaneously under II with a minimally invasive procedure. If it's a pronated foot, usually you will see abduction in the hind foot, eversion of the forefoot, and a dorsiflexion. This is usually because of the tight peroneus tendons. A release of the peroneus longus and transfer to the peroneus brevis usually will take care of this deformity. If this is excessive supination along with that, a split tibialis anterior transfer to the cuneiform bone will help to relieve the deformity. Equinus correction can be performed by gastrocnemius recession or a percutaneous lengthening procedures. Midfoot ulcers, I will leave it to Dr. Ashu. I think he'll be speaking on the Charcot's foot. Coming on to the hindfoot ulcers, as there is equinus or a contracture of the Achilles which causes the metatarsal head ulcers, the alteration of the tendo-Achilles calcaneal forefoot axis causes the hindfoot ulcers, which is mostly because of the unrecognized tendo-Achilles rupture or a Charcot's calcaneal fracture where the posterior tuberosity along the tendo-Achilles insertion is discontinuous with the rest of the calcaneum and goes unrecognized. The treatment, if the distal stump of the tendon is present, tendo-Achilles reconstruction by direct repair or with the lengthening with interposition fascial graft can be done. If the distal stump is not available, tendo-Achilles substitution by flexor hallucis or a peroneus tendon transfers can be done. Now, these are all the surgeries that are recommended. What is the evidence that we have? So, International Working Group in Diabetic Foot Guidelines, which Dr. Vijay is one of the authors, has recommended that in a person with diabetes and abundant callus or an ulcer on the apex or distal part of a non-rigid hammer toe that has failed to heal with a non-surgical treatment, consider digital flexor tendon tenotomy for preventing a first foot ulcer or a recurrent foot ulcer once the active ulcer has healed. The benefits outweigh the harm and it can be done in outpatient setting, as I was telling you. Another recommendation says in a person with diabetes and a plantar forefoot ulcer that has failed to heal with non-surgical treatment, consider the other procedures like Achilles tendon lengthening, joint arthroplasties, metatarsal head dissection, metatarsophalangeal joint arthroplasties, osteotomies to prevent the recurrence of these ulcers once the active ulcer has healed. And this recommendation applies to the patients who have got a plantar ulcer which is unresponsive to the evidence based on non-surgical treatment, is expected to have a high risk of recurrence if the foot structure is not changed, has elevated forefoot plantar pressures, in the case of Achilles tendon lengthening, has a limited ankle joint range of motion not passing near neutral. The possible side effects can be post-op infections. However, the infection rates have been found to be equal both in patients who are treated surgically as well as non-surgical interventions when are done. They can still develop new deformities on the non-operated sites. There can be some gait issues and there can be transfer ulcers on the other toes or other areas. The offloading guideline says that in a person with diabetes and a neuropathic plantar metatarsal head ulcer, consider using Achilles tendon lengthening, metatarsal head dissection or joint arthroplasties to promote the healing of the ulcer if non-surgical offloading treatment fails. Another systemic review which says that there is one high quality RCT which did find small differences, but these were not statistically significant on ulcers healed and time to healing favoring Achilles tendon lengthening along with total contact cast compared with the total contact cast alone in patients with reduced ankle dorsiflexion. And there are 4 studies which says that 80 to 90% of healing in 3 months happens with Achilles tendon lengthening. Another study which says that metatarsal head resections in combination with therapeutic footwear compared with therapeutic footwear alone heal more ulcers. Some retrospective studies which say again the metatarsal head dissections had shorter healing time than the non-surgical offloading interventions. And 2 small lower quality retrospective studies again which mentions that metatarsal head joint arthroplasties in addition to TCC are found to have a shorter time to healing. Only one controlled study reported on a patient preferences, finding higher discomfort in a surgical offloading group during healing, but higher satisfaction after treatment when compared with the therapeutic footwear. Another recommendation by the society is in a person with diabetes and a neuropathic plantar ulcer, using digital flexor tenotomy to promote healing of the ulcer if non-surgical offloading treatment fails. And a larger systematic review shows that an overall healing rate of 97% is seen within a month after using these techniques. Thank you.
Are there any questions for Dr. Shashank? Any clarifications? Thank you for that vast encyclopedia of operations that are possible. Often these are not common knowledge to many treating physicians, surgeons, diabetologists. How can we make this more available to options to everyone?
I think with each passing year, there is growing evidence which has come up regarding surgical offloading, and it is becoming more popular and people are getting aware. However, still, whenever I have spoken about this, I have found many people who have heard it the first time, who don't know that there are some things which can be offered to these kind of patients. But what I can say is with each passing year, the awareness is growing, people are getting aware, and with the more and more people offering this, there are more studies coming up with the increasing evidence each passing year. So yeah, it is getting there, but we are still not...
Long way to go
not,
still.
Yeah, no.
So, yes, Dr. Viswanathan has got a question.
I think I don't have to shout. So I think as you saw the weak, the low, what they expect you to do is RCT.
Okay.
And you should show that surgical offloading is better than mechanical offloading. And Dr. Madhu Periyasamy, I was asking Ashu's name, from Ganga Hospital, he is doing a lot of work and he has shown surgical offloading. I told him to publish it.
Okay.
So that IWGDF will pick out the RCTs. They're very particular that it should be an RCT.
RCT, okay.
And they look at randomization, standard of care. They have a 31 score, Cochrane scoring. And we are trained in Canada for that. So McMaster University. So I think it's very important that we do a publication in peer-reviewed journals, not in some journal, but peer-reviewed journal, which will be picked up by the RCT will be picked up by the IWGDF. Next time, 2027, 2023 was the last guideline. 2027 guidelines should pick it up, and we should
Have more stronger evidence.
surgical offloading can be better than
Correct.
mechanical offloading. So I
Yeah.
think you should have good publication.
Yeah, I think you're right. There are not many randomized controlled trials in this field. Most of the literature that is coming up is all retrospective studies. And the Indian group which you are talking about also has published quite a bit about this. And most of them are retrospective studies where they have published the data they have done over a few years. But we are also thinking, we are in the planning stage with Dr. Felix, and we are also planning 1 or 2 studies which are probably will be randomized to see what evidence that we can get into in this field. Yeah.
Shashank, can I, for the benefit of the house, could you just explain your protocol? How do you select the patients? All of us see diabetic foot ulcers.
So, What we need to understand is medical offloading, as Dr. Vijay was saying, is a good option if the patient is compliant and if the ulcer is in the initial stages. However, any patient who is not compliant or who gets an ulcer again and again, this can be offered to them, that there is another option which can help in healing of these ulcers. The ulcer healing can be hastened by providing this kind of procedure, because what we are trying to do by doing the surgical offloading is trying to get the deformity to get corrected. While when we are using a medical offloading, we are just offloading the thing, the deformity is still present. So if we can take away the cause, probably we can help, but it should be told to these patients, because we are not correcting the rest of the foot, they are still prone to transfer ulcers on the other parts. And after these surgeries also, few of them still develop recurrence.
Thanks, Shashank. Felix has a comment to make.
So what exactly happens in the foot clinic is actually a multidisciplinary team discussions. What we do is basically, this is from our own experience. Even the footwear, what we prescribe is a bedside footwear. Like, I think my orthotic team is here also. So over the last 5 years, what we do is, when we see if there is absent pulse, we call vascular surgeon to come to the bedside. And if we say that we have given a footwear, appropriate footwear, with the help of the orthotic team, they measure it there itself, everything, adjust it. They adjust, it's a dynamic prescription. So they adjust it every time, stitch it, everything meticulously, and we give appropriate offloading, medical offloading. And if it is not continuous, if it is persistently not healing, especially the ulcer in the tip of the toes, or maybe in the plantar aspect in the little lower down, where after giving an appropriate footwear. So we call plastic surgeon and say, we are given the footwear, appropriate footwear. Patient is being educated to wear the footwear inside the house and outside the house. Still we expect at least 2 to 3 months to heal. It's not healed, not even a 0.5 centimeter or 20% reduction. We call them and then they come, educate the patient and try to go for the surgical offloading. And even when it comes to the osteomyelitis, we start off with, if the patient is not septic and patient is kind of stable enough, there is no features of major inflammation, we start with antibiotics and wait for a couple of 3 weeks. And if it's still that there is active discharge or not able to do a biopsy and get a clear microbiological specimen, we call the plastic surgeon to pitch in immediately, and they do the surgical offloading along with the callus osteotomy, which Dr. Shashank told. So it's actually a liaise with your surgeon, and because each one is complement to each other. I wouldn't say medical offloading is fantastic or surgical, both should be complement to each other. That's how we work. And we don't have an evidence to say that we publish, but maybe after 5 to 10 years, we can say that this works, because we need time to show this up. But what I can say is, over the last 5 years, whatever we do, whatever patients we have seen, we have reduced the amputation rate to greater extent. That's what I can say, but the numbers we will give it in the next 5 to 10 years.
You might have also seen in your clinics many patients who are being misdiagnosed, or I will say undiagnosed, with Charcot. So this is the institute where I work, and where I work as associate professor. We have, like Dr. Felix team, we also have a good diabetic foot care team now. Basavaraj is from Vijay, only he knows how we develop this diabetic foot care team so that we can prevent amputation. It's not working. So I'll just show you a few cases and then we'll move forward. So the first case is about Mr. RN. He was a gentleman who came from Ambala. It is a city near Chandigarh. He was 60-year-old gentleman who was type 2 diabetic for 17 years. He had hypertension for 10 years. He just came with a painful swelling of foot, and that was for 2 weeks. Definitely he would have gone to some doctor, physician, who might have seen this patient. And this was his presentation. So anybody can guess what is wrong and which foot is wrong in this whole story? Exactly. So it's quite easy. Anybody can guess it that something is wrong in one foot. And that foot is, sorry, that foot is, that foot. We can see that this foot is swollen, this foot is red, and on touch it was warm. The first diagnosis anybody would think of would be always cellulitis. Because the pretest probability is always high, 90% of the time it would be cellulitis. What happens is that we should not miss these patients. We should not miss another diagnosis in this patient. And that diagnosis can be grave, as Dr. Vijay was saying that it can also be for amputations. So we would like to know further history from this patient. So we wanted to know what was the triggering event. He had a little trauma, he said, not on a stone, and that is causing the trouble to this patient. He had definite symptoms suggestive of neuropathy in form of tingling sensations, numbness, but he did not have any fever. He did not have any prior history of ischemia or blackening of the toes, and we also wanted to know the past history. As expected, he was being treated as cellulitis with antibiotic like amoxiclav, but his swelling was not decreasing. No foot care was advised by the treating physician. He was not advised for any kind of offloading. He had all microangiopathic complications. So we did his examination. We also found out that he is having midfoot swelling, and with warmth, you can see there was around 5.2 degrees centigrade difference between two foot. The left was 36.7 and right was 31.5. His pulsations were bounding. He had some onycholysis. He has loss of hair and shiny skin, and no callosities were present. No guttering, clawing hallux valgus, and no onychomycosis. His motor examination was essentially normal, except for absence bilateral ankle reflex, but his sensory symptoms were there, and on examination also touch pain was diminished, vibration was also diminished, monofilament was lost, vibration perception was 32, and ABI was 1.02. His fundus was NPDR. So now we have a case who presented with 2-week swelling of unilateral foot limited to midfoot. It was not responding to antibiotics. He had significant neuropathy with bounding pulses, no evidence of ischemia. Now what do you think what we should do further? Should we upgrade the antibiotic to maybe parenteral because he is not responding, considering it to be cellulitis? Because this usually happens if you don't know the disease that exists on this planet as Charcot disease. So in an acute state, a Charcot will present with very similar things like cellulitis. It will present as redness, swelling, and warmth. And that is very characteristic of any inflammatory condition, whether it is infectious or non-infectious. So differential diagnosis always would be cellulitis, but you can also consider osteomyelitis and septic arthritis. He never had history of ulcer. So osteomyelitis is very unlikely because it is believed that in diabetes the infection is from out to in rather than a systemic infection, maybe because of infective endocarditis causing bone infection. It's very unusual in this case. Septic arthritis involving only the foot joint, especially the midfoot, is unusual. It is a systemic disease. Gout having only midfoot involvement, that is unilateral, without any forefoot or a proximal or a hand involvement, is unlikely. Rheumatoid arthritis, very rare, isolated foot involvement. Yes, DVT can also be considered in this case, where patient can have a unilateral swelling, but limited to only the midfoot is unusual in this case. So whenever you see a patient like this, never discount a diagnosis of Charcot foot. I'll tell you another patient actually. This is interesting, that's why I am telling you. Because this was a lady who came to me, she was type 1 diabetic for past 26 years actually. 54-year-old woman, and she presented with increased swelling of again the left ankle. You can see as compared to the right, the left ankle was swollen. She also had celiac disease, she was on dialysis. And she was just roaming around with this swelling for past 6 months. So one fine doctor thought that it might be tuberculosis. That is expected. She was having some immunocompromised state because she was on dialysis. So what he did a surgery and took the synovial biopsy of the ankle joint. That further worsened her swelling, and that biopsy was not suggestive of AFB. and the RT-PCR was also negative. Then she came to us and we did all her scans and we found out that she had finding which was very characteristic of Charcot foot. So we thought that in these kind of situations, when you are struggling with making a diagnosis in a complicated case, you can have many things. And one of the things is a swelling which is seen in a patient of long-standing diabetes can be other than Charcot. Yes, it can be tuberculosis. In India, we can have tubercular joint involvement also. And another thing is reactive tubercular arthritis, where you don't see AFB in the joint or in the synovial biopsy. And that is called Ponset's disease. That is called tubercular rheumatism. So you can have that diagnosis also. So we thought that we should differentiate, and I made this table to differentiate, and we published this in Journal of American Podiatry Association. It's a busy slide, but I just wanted to show that you can have sometimes surprises. You can have a complex regional pain syndrome as one of the differential of Charcot's, because they also present with pain and swelling of joints. And I have seen CRPS in hand. I have seen even the Charcot hand also. I'll show you a picture. You can have tubercular arthritis, and you can also have tubercular rheumatism as one of the differentials of Charcot, and definitely Charcot. But in this patient, we managed this patient with strict offloading and total contact cast, and her foot was absolutely normal after 6 months. But it was a tough diagnosis to make in this case. Now this is, I have shown this slide to many people and many students also, but I always show because this is a good learning to us. So this gentleman who was 53-year-old, type 2 diabetic for 9 years, came with swelling of this right foot for past 3 months. He was being offered multiple courses of antibiotics, initially oral, he didn't respond, somebody gave him IV. Ceftriaxone didn't respond, then somebody started meropenem and so on and so forth, considering it to be maybe cellulitis or extensive infection. And very well you can see there is marked swelling of the midfoot as well as the hindfoot region, and there is loss of arches with almost a rocker bottom kind of deformity. So in this patient, why do you think that cellulitis should be a diagnosis? Moreover, osteomyelitis is also very less likely. He never had an ulcer. So in this patient, the differentials again remain the same, but the diagnosis will be Charcot. Unfortunately, I don't know why a simple X-ray was not done for this patient for past 3 months. He was just roaming here and there. And once we did an X-ray, we found this picture. So it is a very sorry figure that unfortunately, I don't know, even my orthopedician said that this foot is unable for any kind of arthrodesis, and I cannot make this patient walk plantigrade anytime. So the only option left to him to make him walk was in prosthesis after below knee amputations. So this is a fallacy that we don't diagnose this condition, and these patients just go on roaming and roaming. We published this as vanishing bone disease in postgraduate medical journal. So it was just a bag of bones, and almost all the bones have disappeared. Patient thought, I never had trauma, but all my bones have gone. So this is the thing about Charcot neuroarthropathy. Now this patient I am showing you because this patient came with swelling of hand. You can see there is swelling, marked swelling at the wrist region, but the opposite wrist is almost normal. So we believe that in diabetes you have glove and stocking kind of neuropathy. So they have both the lower limb involvement as well as the hand involvement. So you can have Charcot of the hand also. It's unusual, but we have to suspect. So in this patient we first suspected complex regional pain syndromes because he presented with pain and swelling, and we diagnosed CRPS by the Budapest criteria. Now we have modified Budapest criteria for diagnosis of this thing. We did all kind of imaging. We did also the bone scan for this patient, and we published this as a Charcot wrist. And this is only the 9th case in the world. People must have seen many cases. I don't know why I don't report. As Dr. Vijay was saying, we should start publishing if we are seeing interesting things. And recently I came across another patient who, you can see the swelling is here, and he also has a swelling here. Interestingly, this patient is simultaneous hand as well as the foot Charcot. So this is very interesting. So you can have these kind of presentations, but we have to closely look at. You can very well see significant swelling of the left hand and significant swelling of the left foot in a single patient. So these are surprises that sometimes throw you, but you have to diagnose Charcot. This is concurrent wrist and midfoot Charcot neuroarthropathy in this patient. So whenever you see these kind of patients, try to differentiate between cellulitis and Charcot. Cellulitis is usually kind of an acute event. a patient will have a fever. Patient with Charcot usually have a longer history. They might not have fever. Their serology would absolutely be normal ESR, CRP, ProCal, TLC. But in a given patient of Charcot, you will have the cellulitis, you will have increased ESR, increased TLC. A cellulitis is a diffuse process. You can have from forefoot till the leg, you will have swelling. But in Charcot, you will have very restricted swelling because it involves predominantly the midfoot joints. Yes, it can involve the hindfoot joints also. The swelling would be very limited. Therefore, diagnosis is more of clinical in these patients, but sometimes it's very difficult to make a diagnosis just on clinical examination. So you have to rely on radiology, maybe like X-ray or MRI. So they are very characteristic and diagnostic of Charcot's in this patient. But try to differentiate between these two. The diagnosis overall essentially clinical. In a given patient who has a swelling, unilateral, restricted to midfoot region, no fever, normal leukocytes, always consider Charcot also. And then plain X-ray would be helpful, and whenever you write for X-ray, kindly write as a weight bearing X-ray lateral and AP. If you want, you can also have an oblique film. But this is very important. So we recently published this data about Charcot, about varied presentations of Charcot. This was a multicentric study from the European countries, from Greece, from Germany, from England, and also from USA. So we had 734 patients of Charcot, and we wanted to know what are the characteristic features. So most of these patients have a long duration of history of diabetes. You can see the median duration of diabetes at diagnosis was 15, and midfoot was the most common affected site in these patients. So this is one of the largest study in the world, which has taken almost many patients across 3 continents, America, Europe and Asia. And we contributed the largest number, almost 2/3 of the patients were from our center in this study. So the lesson from presentation till yet is unilateral foot edema and warmth in a diabetic patient make a suspicion of Charcot in your patients. Now coming to further examination. So whenever we see that the foot is warm, then it should be quantitated. Anybody can say, I feel that foot is warm, but another person who examines, he say, no, I don't feel the foot is warm. So you have to quantitate it. So can you tell me what is the right answer? It's quite easy. Temperature difference between 2 feet, which is diagnostic of active Charcot foot, is ABCD. Exactly. So my purpose is done. So almost everybody knows. The diagnostic is 2.2 degree Celsius. It's not Fahrenheit. Unfortunately, nobody knows from where this 2.2 came. And Dr. Vijay was mentioning about Freiberg. So this cutoff was given by Dr. Freiberg and Dr. David Armstrong, because in 1996, they were just trying to develop an instrument that can measure temperature. So they were working with MIT and they got an infrared thermometer at that time. And without any prospective studies, they just gave this cutoff, and still we are following this cutoff. So we are doing these studies to challenge this cutoff, that why 2.2 degrees centigrade is said to be diagnostic. So I'll get back maybe in next 2 to 3 years regarding these cutoffs. We need to challenge it. So diagnosis, as I mentioned, is by infrared thermometer, but also by radiology. So whenever you see an X-ray, these are simple things that you can see on an X-ray. One thing, the first sign would be flattening of the metatarsal head, and that your radiologist can tell you, but you should also know how to see it. And very important is, there will be focal demineralization, because Charcot is a very limited disease of midfoot, suppose. So it will involve demineralization of midfoot bones, like tarsal bones, like cuneiforms, or navicular or cuboid bones. Otherwise, strong indicator would be absence of any soft tissue involvement, like ulcer, polyarticular distribution. And remember that Charcot is a disease of bone and joints. Therefore, it is called neuro-osteoarthropathy. Neuro because occurs in neuropathic patient, osteo means bone, and arthro means joints. So always the findings would be periarticular. So this is very characteristic, and that differentiates it from osteomyelitis, where the diaphyseal part of the bone is involved, not the periarticular part of the bone. Otherwise, in chronic Charcot, you can have these kind of pictures, because there is osteoclastic activity which continue to resorb the bone, and then you can have this mortar and pestle appearance, the proximal phalanx entering into the distal phalanx, You can have completely resolved metatarsal like pencil-like appearance or a sucked candy appearance like this. But this is a feature of chronic Charcot, and this is really needs your care. Otherwise, these 6 Ds are fondly remembered like distension of joint, destruction, dislocation, disorganization, debris, and increased density in chronic Charcot. So these 6 Ds are said to be sine qua non of Charcots, but don't let the patient to enter into these because this is feature of chronic Charcots. Otherwise, Dr. Freiberg has given this classification that is called Sanders and Freiberg. On the basis of that, we classify into forefoot, midfoot and hindfoot Charcot. The most common is type 2 and type 3. So you can see almost 80% of the joints are mainly the midfoot joint, that is intertarsal and the tarso-metatarsal joints. Otherwise, you can have the forefoot involvement or hindfoot, that is type 4 and type 5. So even in our paper, we found that almost 70% of patients were having the midfoot joint involvement. But many of the times X-ray is normal. Like in my patient I showed you who came to us just within 2 weeks of the swelling. It usually takes around 15 to 20 days for the changes to appear on X-ray because it requires 40% of the bone to be resolved or dissolved before it can be seen on an X-ray. So your X-ray would be normal, but still you are suspecting Charcot. So what to do? The next step would be MRI scan. And MRI is said to be almost more than 95% sensitive for diagnosis of Charcot neuroarthropathy. And only thing that I want you to remember is that these patients will have typical bone marrow edema pattern, which is periarticular. So they will have on T2 weighted MRI films, you will have hyperintense, it will appear dark or white on T2 weighted films, and that would be multiple bones would be lit up and they would be mainly periarticular on MRI. But in some of the patients, patient might have some pacemaker, patient might have some hip implants, still MRI cannot be done and you are still suspecting Charcot. The next best step is nuclear scans. So we do also nuclear scans in patients where we cannot do an MRI. Otherwise, it is recommended when a patient is having ulcer, patient is probably having osteomyelitis and you strongly want to differentiate between these two or to look at quiescence. So most commonly we do technetium MDP 3-phase bone scans. Dr. Felix must also be doing these MDP bone scans. Do you do it? Okay. But this sometimes is very helpful. So in our patient, he already had a history of hip implant. So I'll show the picture again. So this was a picture that I was showing you. His X-ray was absolutely normal. So he went ahead with a bone scan. And you can very well see typical one foot is involved. The other foot is absolutely quiescence. The left foot is involved and typically in the midfoot region, which is hot. And this is the anterior images and these are posterior images of technetium MDP bone scan. So this can help us in diagnosis of Charcot foot. So this patient was managed with total contact cast, and again all these cases were published as varied presentations. Now I'll show you another interesting case. This was acute Charcot, but this patient presented with some other history. So this was a lady, 43-year-old, who had type 2 diabetes of 6 years. She had some swelling in 1 year back, and then she is developing progressive deformity of the foot. She had a history of swelling around 1 year back and treated with courses of antibiotics, not otherwise any offloading. And when she presented, this was a picture. You can see that there is some loss of arches. She already had a prior amputation here. She had swelling of this foot when she presented 1 year back. And this was around 2 to 3 years back. So problem was, I asked her, she had all neuropathy and she did not have any vasculopathy. So I asked her, did your doctor did an X-ray 1 year back? So she told, yes, they did an X-ray. I'll show you an X-ray. So this was an X-ray 1 year back. This was relatively normal. So the diagnosis of Charcot was missed. She continued to walk on this. She might have acute Charcot. And then Charcot undergoes spontaneous remission. And she went to another doctor. 5 months later, this was the picture. This was complete disorganization, dislocation and fractures. But when she presented to us, she was in this stage. So this is how Charcot progresses. So now this is the stage of sclerosis. But problem is she has lost her arches and she is at very high risk of foot ulcers. So this is again an tyranny of misdiagnosis or undiagnosed Charcots. So how to treat when you have diagnosed a patient with Charcot? So the best answer would be you have to look at the pathophysiology, that why does Charcot occurs. So we published this paper regarding the pathophysiology of Charcot in PLOS 1, and we wanted to know that what is happening in these patients. So you can have the inflammatory pathway for Charcot, you can have a non-inflammatory pathway, which are mainly because of RAGEs and ages, that is advanced glycation end products, or inflammatory pathway because of recurrent trauma. There is increase in these cytokines of TNF alpha and the IL-1 beta, which stimulates the osteoclast, and then it causes active Charcot and bone dissolution. So we thought that we should target each of these steps to inhibit this process or to treat these patients. You can target this recurrent trauma by total contact cast. You can target the inflammatory pathway by giving steroids. You can target the osteoclast by denosumab or zoledronic acid, that is bisphosphonates, and you can improve the bone mineral density by giving teriparatide. So this paper that we published, then we thought that we should generate some evidences, and as Dr. Vijay was saying, the best evidence in science is randomized controlled trials. So this was one of the paper from Netherlands, Westbrook, regarding denosumab, that is anti-rankle antibody. This was not a randomized controlled trial, but they showed that if you are using denosumab in your patient with acute Charcot, you can have significant decreased time to remission. As compared to patient who was not given denosumab, cast was required for 180 days. If denosumab was given, it was required only for 120 days. So that was a very good outcome. But problem with this study was it did not have any controls. It was not randomized controlled trial. We thought to work with steroids because steroid is one of the pathway by which we can inhibit the inflammatory pathway. So this is the first trial in the world with methylprednisolone that we published, and it had 3 arms: TCC with placebo, TCC with zoledronic acid, and TCC with methylprednisolone, which was given 1 gram to inhibit the inflammation. We found out that inflammatory markers, we measured those IL-1 and TNF alpha also, they were significantly reduced by giving methylprednisolone, but it did not lead to earlier remission, or the time in total contact cast was not reduced with methylprednisolone. So this was a negative trial, but still it is very well cited in all the guidelines to suggest that this does not work. And then I thought that I should just review all the literature, whatever is there regarding the medical treatment, maybe with bisphosphonates, calcitonin and all. So I did this meta-analysis and systematic review, and I could find strangely only 9 to 10 studies related to the treatment of Charcot with medical therapy in the world. And we found out that if you are using any kind of pharmacotherapy, it did not reduce time to remission. In fact, it increased time to remission in these patients. So we concluded in this paper that presently no medical therapy work for patient of Charcot. So nothing is working. How to treat? So this is a paper that we recently published related to the patients of Charcot in chronic kidney disease, because when we were reviewing our patients of Charcot, we have now almost around 800 patients of Charcot, and we found out that almost 43% of these patients have some kind of diabetic nephropathy. And this diabetic nephropathy, you know that the CKD itself can be very killing for the bone, and that can lead to fracture. So we found out in these patients, when we are offering denosumab to patients of CKD, it was helping in improving time to remission, and this was a randomized study that we recently published. So probably this will come in future IWGDF guidelines. This is one of the first randomized study for denosumab in patients of Charcot in the world. So at present, the only standard treatment would be a offloading knee-high total contact cast. And once the patient is in remission, you can shift your patient to crow boots, that is Charcot restrained orthotic walker, or if it is 4-foot or a kind of a mid-foot Charcot, you can also shift them to a modified sandal. So this is how these kind of things are made. These are the 3-layer fiberglass knee-high non-walking total contact cast, and this is the only treatment at present in the world for treatment of Charcot. The IWGDF guidelines also recommend the only treatment would be knee-high device. Do not use bisphosphonates with PTH, methylprednisolone. After our study with methylpred and PTH, this came as moderate evidence with strong recommendation, and they are still suggesting not to use denosumab because this was in 2022 when they reviewed the literature. Maybe this might change in 2027 guidelines. So now you have diagnosed Charcot, now you starting treating Charcot. The next question is how to follow these patients of Charcot. So what we do is, whenever these patients are on TCC, we call these patients after 15 days, we ask them to remove the cast, we again take the temperature difference between 2 feet, and this is how we follow the patient by these kind of infrared thermometers. Maybe this, which is very popular in COVID days, and now I have these kind of thermometers which are very sensitive. So this is how the temperature decreases. This is again one of the paper from David Armstrong's group from when he was in Texas. They showed that initially the temperature difference between 2 foot was 10 degree Fahrenheit, but it takes quite long. You can see the temperature is gradually falling between 2 feet, and only by 9 to 10 months it has reduced down to normal. So the lesson learned is, whenever you give TCC to a patient, you have to be very patient with the patient. The patient will ask, doctor, how long I would have to be in TCC? It will take 6 to 8 months. This is the usual time for remission of these patients, in these patients. So once the patient is dead, then you can shift them to crow boots. So definition of remission is always a temperature difference between 2 feet less than 2 degrees centigrade, and it should be checked at least twice 4 weeks apart. You can have other definitions of remission also. Now we are working on other definitions, maybe more sensitive definition other than temperature, maybe PET-CT, SUV max, and we'll soon come up with some SUV cutoffs for diagnosing or the remission of these patients of Charcot. So this was the outcome in my patient after the offloading for 6 months. You can see there is no difference, there is no swelling, there is no erythema, and this patient improved without any abnormality. So it is very important that first suspicion, then treatment, and then follow-up of these patients. But you have to follow these patients quite long, because this remission, what outcome I showed, is not still ideal. You have to have long-term outcomes in these patients. These patients should not have any deformities, because as Dr. Vijay was also saying, this lead to amputations. No fractures and plantigrade ambulation is the thing. So the next thing is, have you seen recurrence in Charcots, Dr. Felix? Yes. So it's quite common, because once we shift these patients from TCC to maybe a simple boot, or the patient start walking very ardently, problem is his neuropathy is still persisting, his diabetes is still persisting, he has all predisposing factors for Charcot. They can develop recurrences. So we still have to follow these patients, though they might not be in TCC, but follow these patients very rigorously. And this is one of the paper from Stark's group, and they found out that 34.9% of these patients relapse. So don't forget your patients once the patient is in remission. And don't forget your patients again, because of one more thing is that they fracture after some time, when still they are in remission. Why? Because this is a paper from, very interesting paper from Sinacor. He showed that the foot bone mineral density decreases with the Charcot process. One, because of offloading. Second, because of osteoclastic activity. And then they develop fracture maybe after 1 or 2 years. So it's very important that you offer them some kind of good offloading footwear. And this is one of the biopsy papers from La Fontaine group, who was my co-author in our paper. And he showed that there is increased osteoclastic activity in these bones, foot bones, when they have developed Charcots. And this is just like osteoporosis, localized osteoporosis of foot bones. So we thought that if it is localized osteoporosis, why cannot we increase the bone mineral density of foot bones? So we did this first study in the world with teriparatide. I think Basa was there when we started this study. You also did on teriparatide something? Vitamin D. So this was on teriparatide, the first study in the world, again a randomized study for Charcot foot. And what we found in this study is that there was significant increase in the foot bone mineral density if we are using teriparatide, which prevented fracture of these patients who had Charcot. So overall, I would say that be very patient with your patients, and sometimes Dr. Felix group has also published regarding mortality in Charcot. So this is a paper regarding mortality of Charcot. So if you misdiagnose a patient with Charcot, this will be really a curse, because these patients will lose life very frequently. So this was a study in which we followed 260 patients of Charcot and compared with twice the number of controls who had diabetes, who had neuropathy, who had similar duration of diabetes but never had Charcot. We followed these patients and we found out that these patients of Charcot had higher mortality as compared to a patient of diabetes who does not have Charcot. Moreover, one-third of these patients land into amputation after some time because of deformities. So overall, I would suggest that diagnosis of Charcot is really essentially clinical. First, you need to know this disease. Then you can do a radiology like X-ray and MRI. And once you diagnose, please treat only with knee-high, non-walking, total contact cast, and no medical therapy is effective for that. But probably we need to understand more about this disease, the pathophysiology, that why this disease is occurring, because 60% of patients have neuropathy, diabetic neuropathy, but hardly 1% develop Charcot. Why this is there? And we have to have long-term goals to prevent deformities and amputations in our patients. So thank you. Thank you, Dr. Basav and Naik.
Thank you, Dr. Ashu. Such a wonderful presentation of various clinical cases and management of acute and chronic Charcot foot. This session is open for discussion. Any question and comment from the floor?
Dr. Rastogi, that was a very nice presentation, and Dr. Anjali from Chennai. In the higher grades of Charcots, grade 4, 5, where the bones are really beyond, recovery, do you offer implant devices? Because that's what the surgeons advise to stabilize the foot, at least as something to prevent amputation. So titanium implants and joint reconstruction, is there any role for that? Can you share your experience?
So I believe that you are talking about chronic Charcot.
Yes.
So in a patient who already had an acute Charcot which was being missed, which was not being properly treated, now he had fractures, fragmentation and dislocation. You're absolutely right. In those patients, to make the patient walk plantigrade in a good modified footwear, we need to do some kind of surgical things also. And our orthopedic team also do the arthrodesis, especially of when they are having hindfoot Charcot, because hindfoot Charcot is very notorious and the most difficult to treat. So they are doing all kind of calcaneotibial nailing. They are also doing many kind of midfoot arthrodesis in these patients.
No, the X-ray that you showed, vanishing bones, sometimes we see really bad foot like that, where the bones are gone. So there, what is the role for all this?
So implants, I don't know much about the when multiple bones are involved and you put multiple implants, usually they are not successful. So if you are having a single bone involvement, you can do an implant. Maybe the most common implant that I have seen in our center was talar implant, because talus was the bone that is most commonly involved. But suppose you have almost 20 to 30 joints involved, like in the midfoot involvement, like all the cuneiforms have gone, the navicular and the cuboid have also gone, the calcaneus is fractured and talus is also fractured. It's just impossible to get an implant in this patient and to make him walk again.
Probably what you're referring to is the external fixator and the internal fixator. So external fixator is useful for ankle joint injuries. If the ankle joint is involved, you can put an external fixator. But in Charcot, as Ashu said, it's too late. They're present very late. So fixators don't work.
Yeah.
So, but in ankle joint infections, you can definitely put an external fixator. We have done about 200 cases putting external fixator onto the ankle joint injuries. We saved them also from a higher amputation. So I think external fixator is good. It's more simpler than the internal fixator. And that's what you meant by implants. Charcot is very difficult.
No, it's very difficult. One thing is these are very brittle bones. So my orthopedic colleague there, I think you are an orthopedician.
Yes, Charcot poses great challenge, even for experienced surgeons, because of its complex pathophysiology. You nicely pointed that whatever disease, we are addressing the symptom, not addressing the pathophysiology. And if you spend patiently time with your patient, you can catch the disease at an early stage. This is what Paul Brand told. Previously, Charcot is very common in Hansen's, now the diabetes. So Charcot is a 5-star case, is equal to king cobra. For that, if you want to address Charcot, you should know 3T. That is trick, technique, and trend as well. And as the pathophysiology of the Charcot is denervation-induced degeneration. See, primary pathology predominantly in the neurological component. It is very difficult, you know pretty well that whenever there is a nerve injury, it should be addressed at an early stage. In Charcot, it's a long course. And you pointed that Charcot foot, whatever software or hardware, that is software means your brain, your technique, whatever it is, and hardware is pins, screws, or Ilizaro, or whatever external fixator. Because of the disuse atrophy, the bone is so fragile, do no harm. That is the medical slogan. So, even if you put screws, pins, KYs, whatever it is, you are doing harm to the patient. Already it is damaged. You are doing further damage without knowing them. Consequences, what will happen after putting the metals? Metal is always a metal.
Yeah.
It will not. So, second thing, me concern, if you catch the disease at an early stage, TCC is the gold standard across the universe. It may take time, but it offers tremendous result. But one thing, as you pointed, bisphonates or zoledronic or whatever it is, will never ever do. And most of the Charcot patient, they are coming with chronic ulcers. Especially, as you pointed, heel ulcer won't heal. Heel ulcer never heals. And wound is the master. It will dictate you. It will guide you. So follow it. And Charcot, again, I'm telling you very honestly, I burned my fingers so many times by using over enthusiastically with metal spin screws. It is increasing numbers in my surgical register. Ultimately, I miserably failed to produce cosmetically acceptable and functionally useful limb. Thank you.
Over the next few minutes, I'll be actually representing my team who is actually working with me in making this happen. And can I ask my orthotic team to stand up, please? And because I'm actually representing them, and I have my vascular surgeon here, plastic surgeon here, and educators here, all are here because I'm just representing. It's like representing the team and trying to explain because probably I'm blessed to be here to work with this team and try to explain the concept of offloading, just to understand that how much magnitude is there to understand that this particular offloading is neglected in Indian subcontinent. That's the idea here. Not to say that you have to prescribe this, to understand that offloading is a very, very important for every physician, every surgeon, everyone who practices medicine, especially the primary healthcare physician. So as I mentioned, it's a multidisciplinary team. And I just talk about the biomechanics. See, suppose if I walk, I'm actually walking with a lot of stance to heal. I'm not going to the detail of this, but remember that in diabetes, because of the motor neuropathy and also the sensory neuropathy, they actually have different gait, credence, so many things. So it changes so many ways. So when they are walking, they are not actually using the same stance, stride or swing what every one of us are doing here when we walk. So that is the reason we need to understand that diabetes patients with diabetes has a different gait, credence, everything, which I'm not going to the detail because that itself is a biggest workshop we can do. So what exactly means is that whenever you are seeing a patient, try to understand what gait, how they are coming in, because they may be having osteoarthritis, they may be having an osteoarthritis hip, maybe having an limping gait, quite a bit of a gait may be there, which I am not going to detail, but remember that that is very, very important when you are prescribing a patient with offloading maneuvers. So in terms of offloading, gait training and physiotherapy is very, very important because it's like if I buy a car and I don't know how to drive, that means the car is going to stay back in my home or my bicycle is staying at I don't know how to probably drive both of that. So that's why it's very important that whenever you are prescribing a footwear, you need to educate the patient how to walk and how to make sure that they walk with appropriate stance and the credence itself, it's very, very important because it's just education about the education, the physiotherapy and gait is very, very mandatory for the patient, because what we are trying to achieve here is the prevention of ulcer, yes, as well as amputation, and you're treating. So it's important that, as already Dr. Ashu said, that Charcots can recur, that foot ulcer can recur almost up to 50 to 70% if you are not educating the patient appropriately. Because patients with diabetes foot ulcers die much earlier if they have an amputation. We also proven in our own study in CMC, well, although it's a retrospective data, it says that patient with amputation dies 4 years younger than patient who doesn't have an amputation. That means its prevention of amputation is very, very important. What I am trying to talk is needs an evidence. So we are talking about evidence because, and it revolves around the IWG-DDF guideline 2023, and try to fix up how we can use the existing resources to make use of, so that what we are doing is appropriate, adequate, and it prevents a foot ulcer and also treat the foot ulcer particular point. One of the very important need to understand is that diabetes is nothing but a modern day Hansen's, because whatever the deformities you see almost look similar to the Hansen's patients who was untreated in the past, but now we are able to diagnose Hansen's much earlier. They don't come with the deformities. And secondly, you need to understand that what is the main difference between Hansen's and diabetes is that after they develop an deformity, the deformity stays for longer duration because the lepromatous, leprosy, bacilli dies after the therapy, and there is no progression of the major progression of the deformities in Hansen's. But however, in diabetes, they have to live with diabetes for years together. So in spite of having a good glycemic control, could be a polymorphism, environmental factors, etc., will continue to create a problem for patients with diabetes foot ulcers, and also will end up having a recurrence, amputation. So it's a dynamic problem which is ongoing in patients with diabetes when compared to Hansen's. That is why the deformity in Hansen's we treat with the offloading maneuvers which are already been done for Hansen's, but we need a dynamic prescription wherein the patient will come to us today, have a nephrotic syndrome because of proteinuria, they will develop swelling of the legs, and then you need to adjust the straps, and next time when you come, you would have treated with appropriately with an AC or ARB, and then the edema subsides and the straps won't be looked at, and it will be loose and it will have a friction in the dorsum of the foot, and then they come back to the ulcer. So that is why our team thought that every patient we need to prescribe a bedside footwear. So any patient with diabetes with foot ulcer come, we give a bedside footwear, not a footwear as a prescription. So they stand together along with us, the team, and they prescribe so that it become dynamic. We don't do in patients without foot ulcer because that's beyond our capacity to manufacture as well as give therapy. But if you are able to achieve that, probably that's the goal we are looking at in the future as well. So in terms of amputation, in terms of the offloading, we divide them to let's say three parts, forefoot, midfoot and hindfoot. But however, if you look at carefully, the orthopedician or a surgeon will look at the midfoot, hindfoot or forefoot a little different, but in terms of offloading and looking at the way the footwears are manufactured, and also the gait, you probably need to call the forefoot as the mid-metatarsal rather than the real demarcation line which is given in the textbook. So there are a lot of offloading maneuvers. I'm just, my talk is to highlight these are available and not to say that you have to prescribe this, because the guidelines are very clear to guide us and to tell us what to be used, but we have a lot of offloading devices in our shelves, but how to use, which to use, we will try to see whether we can use the existing IWG-DDF guidelines and try to manipulate in such a way that how as an Indian physician we can use it appropriately. So in terms of the footwears available, if you say anterior rocker or anterior wedge or half shoes, these all are common names interchanged with footwears in Hansen's disease as well as diabetes. So half shoes, anterior rocker, anterior wedge are almost same, but what we call as anterior rocker, you can visit our stall in stall number 9, am I right? Stall number 9, you can see all the footwears there, so that when after going that, they will be able to explain in a better way what exactly is the difference, because anterior rockers are manufactured within the hospital, which is much easier in a larger scale, but in your center, wherever you are, you may be finding it difficult. So what you might be using is that half shoes are an anterior wedge, which is much easier to available. But one more very important is that whatever footwear we are using has a rocker. If you look at carefully, any men who are sitting here, if you are wearing a shoes, you can see there is a rocker already. That rocker we are just exaggerating in patients with diabetes so that it is off the ground. That means that particular part is off the, let's say, the anterior rocker will be like this. So it will be probably, I would say this may be around 7 degrees. So that if you are able to look at the rocker footwear there, you can see that it will be around 12 degrees or 15 degrees. But we give patient to patient difference because when they are taller, we probably little exaggerate. When they are shorter, may like me who are, God created me a little shorter, probably I need a lower degree of rocker. So that is how we actually prescribe footwear. So diabetes footwear prescription is highly dynamic and individualized. That is why it is called customized footwear. That is very, very important because if you look at your footwear, let's say it's 7, 8, 9, 10. But if you do a customized footwear, it will be 7.25, 7.45, 7.8. Some of that numbers will come if you really look at that. So that is why patients with diabetes need a customized footwear. So what exactly is complete offloading? Partial is, that means part of the foot is down on the ground and part is off the ground. What is complete offloading is already Dr. Ashu said that is completely off the ground. Suppose I have a foot ulcer in here, then what will happen is I'll off the ground, then I cannot hop. So that is difficult. So it is very important that the patient needs to be given appropriately. So what exactly are available? Wheelchairs, crutches, walking frame, everything is available, and total contact cost. So, so all are available. You can take a photograph and look at later. But you should use appropriately depending upon your availability and your center, how it can be procured. So just putting all together, how do we fit in the International Working Group guidelines? Let's say the patient comes with a foot ulcer, let's say forefoot, midfoot or hindfoot, whatever it is, the first choice as of now it is TCC, but TCC is a reasonable offloading application. You can actually apply in your day-to-day practice if you know how to use it. Now the YouTubes are there to use it. But remember that there is now evidence to suggest that if the patient able to use a air boot, which is freely available off the market, and also apply a restrained in the mid part of the calf, you make it like a TCC. That is almost equal, both of that. Even some of the studies, as though it's not an RCT, some of the studies, but some RCTs are definitely shown it to be high of value. So if you are not an expertise in terms of applying TCC, probably you can use an air cast boot with a restraint in the center. This is a complete, it's a air cast boot with exactly what is applied in the Western countries, but what Dr. Ashu showed is actually the air cast boot was actually really shown by the great Paul Brand. So he was actually the first person to apply TCC in patients with Hansen's, but what Ashu showed was the really invented TCC, but what is here is actually the complete TCC. I'm not going to the detail of whatever here is in the interest of time, but you can see this is how it has been restrained, and so that you can use it, which is equal to the TCC. What is the second one? The second one is you can go to the stalls in stall number 9 and look at and see that what are the various offloading devices which we can use. You feel free to go and look at. So that is why the stall has been put, and you can visualize all the maneuvers, offloading maneuvers for forefoot, midfoot and hindfoot, which will be very, very easy to understand and you can feel that which will be probably the second best maybe should. But if you look at Indian patients, if you ask them to apply a TCC on the upfront, what will happen is, our mindset is that TCC is, if you have a plaster of Paris, that means it is only for patients who had a fracture. So that is our mindset. And the difficulty of the explaining as well as convincing the patient is as low as 10% is in Western countries also. Some of the studies are shown as low, lesser than also, but remember that TCCs. So that is why this half shoes and other maneuvers which I shown are actually helpful in terms of the reduction in the healing time. But there is no RCT comparing saying that TCC versus anterior rocker. There is no RCT really there, but there are few retrospective studies with the credibility may be questioned on that are available currently. And suppose the patient is come to you with foot ulcer bilateral, when so I'll just quickly in couple of minutes because there is an oration starting. So this is the half shoes, and and if you have a difficulty in procuring the half shoes, which you can see in the stall number 9, we can see that this is the Yarkas boot, which we can use it very easily. So it's very easy to procure footwear, and just you can see this is the anterior rocker, this is the half shoes, and this is the difference between anterior rocker and half shoes. So this is already shown by Dr. Shashank Lamba. I'm a little nervous after seeing that small cheetah baby. That's how the rhythm goes off when you are going. And this is a metatarsal bar which you can probably use it in your setup if you have the capacity to use it, because it's just a simple rubber we can fit, and you can talk to our orthotic team if possible and understand that. And also what we do is when the patient has a difficulty in holding the footwear, we have an extra strap. This is what I said, the dynamic prescription comes, because when I prescribe, I sometimes prescribe that anterior rocker with elevation of maybe around 10 degree or 12 degree, and then they come and say that we make them walk and it's slipping, so we put one more strap in the ankle. So it become a high ankle offloading device, which is actually the second best for any patients with anterior foot ulcer. So that is why I'm saying you always need to see patient basis and never put a metatarsal within, which was practiced in the past, which was for the Hansen's disease, but that is no more used. So in part of midfoot, probably is very difficult. You need a customized molded insole so that the patient should be adequately mapped in terms of the foot deformity, and then continuously monitor, and it's very difficult to treat this. And what we use is the midfoot orthosis, which is very easy to manufacture. No, it's very, very difficult. So, but needs an expertise. But if the patient has a midfoot ulcer, the ideal would be probably the best I would suggest in any of the setup where you don't have orthotics is probably the Yarkas boot. Okay, suppose the patient comes with a hindfoot ulcer, very difficult because probably needs a surgical intervention. We hand in hand with the surgeon. If there is a vascular compromise, you need to club with them and do all of maneuvers to make sure that there is adequate blood supply. What in Indian context, what we are using is probably the hindfoot orthosis, but remember this again is difficult to manufacture. But whatever certain, then the idea here is to understand that offloading is very, very important in terms of the foot ulcers. Suppose the patient has a foot ulcer in the dorsal aspect, then you have to use the adequate softness in the straps, so that you have to put an proper covering so that there is no friction. So this here, when you have a straps, it's an uneven friction. When you have it's combined with the heel counter, the friction goes down. So, and we yet to have the biomechanics of this particular footwear done, but whatever we have prescribed, we have not seen any, reduces the healing in much faster. So this is probably the last slide. You can probably take a photograph. Putting all together what we thought we should put together and have an algorithm where if there is a 4-foot ulcer, anterior wedge, metatarsal bar of your choice or rocker of your choice, or TCC is the best. I have no disagreement in that. If there is a midfoot, TCC probably the best, but if you don't have that, you need to use appropriately. I'm not going to the detailed granules of everything, but whatever certain done, after the ulcer heals, you need to follow up the patient, give an appropriate footwear. I'm not going to say that MCR is best or Poron is best. I'm not going to the detail of this, but remember that long-term follow-up is very important, and you can also see the